Thank you very much for having me. It's an honor to be here. I thought I understood what to do with dual antiplatelet therapy, and then after those two talks, maybe we need a little discussion, and hopefully, this area is a little bit more simpler. Um, so, in terms of antiplatelets after TAVR and TEER, it's kind of a tale of two worlds. I was asked to give this topic. I think in the TAVR actually literature, we have a fantastic amount of data, well-defined practices with multiple randomized controlled trials addressing this topic, and I think we have a pretty clear outline of how to manage these patients. Whereas TEER is pretty much the exact opposite. There's actually no randomized data, and it's reliance a lot on registries and practice extrapolation. I'll hope to shed a little bit of light on that topic as well. So when you talk about the thrombotic and bleeding risk in TAVI patients, I don't know the exact proportion. I think I've read indifferent by our criteria, as Professor Kim mentioned, but they're more likely in the 2/3 to 1/3. So the vast majority of patients have high bleeding risk, and we're trying to balance thrombotic risk, that just like in the PCI patient population, but along with the issue of prosthetic valve thrombosis in terms of thrombotic risk. And obviously, the bleeding risk tends to be very high with a lot of elderly patients, and they have underlying anemia and bleeding history and renal failure, but also the presence of Heide syndrome and angiodysplasia, and so they're at increased risk for GI bleeds just from the aortic stenosis itself. Now, just to give some background in terms of the TAVI versus SAVR data, this is meta-analysis of 7 studies. I think the concept that stroke risk is lower with TAVR, that's been pretty much well shown across multiple studies. Disabling stroke tends to be less, MI tends to be less. Major bleeding is definitely less with TAVR versus SAVR, but we do have increased risk of vascular complications, obviously, with the large bore access. And as we look across the studies, major stroke has gone down tremendously as the technique has improved from, we look at the earlier partner trials and initial CoreVav in the prohibitive and high-risk groups, the stroke risk was about 5%. And then now in the current studies with the low-risk partner 3 and the Evolut low risk, the stroke risk is under 1%. But there's an ongoing risk out to 1 year. So there's initial risk and then there's risk out to 1 year. Similar with major life-threatening bleeding, that's been dramatically decreased from the 10 to 15% risk initially, now down to the 2 to 3% risk of the latest low-risk trials. But there's also almost the same amount after the first 30 days in the first year. So these patients are at high risk of both thrombotic and bleeding events. So the last guidelines, what do they say for this, for the use in the TAVR patient populations? For the European guidelines, class 1 indication for lifelong single antiplatelets. And then there's no specific recommendations for PCI patients. In the American guidelines, there's actually a 2A, a recommendation for single antiplatelets, and for patients at low risk of bleeding, 2B for the use of DAPT. And we'll show the data kind of better on this. For concomitant anticoagulation, lifelong oral anticoagulation is class 1 for the European guidelines. No comment about antiplatelets and nothing in the American guidelines yet. So where are we at with the data? There's been actually multiple trials we have in this range looking at patients with TAVR. In patients without indication for antithrombotic therapy, we have 3 trials looking at specifically antiplatelet therapy. We have 4 trials looking at antithrombotic therapy. In those that are on anticoagulation, we have 3 trials looking at that as well. So we have a fair amount of data kind of to make definitive recommendations on what to do with these patients. So first we'll look at the DAPT versus SAPT trials, and we have 2 trials. The R trial is the smaller one, 222 patients. The popular TAVI cohort A, which is the no indication for anticoagulation, has 665 patients, so a fair amount of patients. Both looked at 3 months DAPT and then 1 year, and then continuing single antiplatelet for the year. And if we look across, both trials showed similar results. Both, of course, as you would expect, higher bleeding risk in the DAPT arm, and then similar in the bigger popular TAVI trial, similar risks of MACE, whereas the MACE was actually higher in the DAPT arm. So across, I think both trials, we can say that DAPT didn't decrease MACE, but only increased bleeding. And so single antiplatelet therapy seemed the way to go for isolated TAVI. If we look at those with looking at oral anticoagulation. So this is patients without established indication. As you know, a big issue in the TAVR population is HALT and early leaflet thrombosis. And so the concept was, should we put patients on anticoagulation for the prevention, similar to what often is done in the surgical literature for the early 3-month courses of anticoagulation? This used it longer. So the Galileo trial was the bigger trial, the initial trial, looking at 1,600 patients. They had no indication for anticoagulation. They used a lower dose rivaroxaban, so they added aspirin for the first 3 months versus what was standard at that time, DAP for 3 months, followed by aspirin. And so looking at rivaroxaban of 10 milligrams, what we saw was that both increased MACE and increased bleeding. So bad for thrombotic events and bad for bleeding, the use of anticoagulation. The Atlantis used a standard dose of apixaban, and so this didn't add the antiplatelet, so that's why you're going to see a little bit less bleeding in this group of patients. So just oral anticoagulation, and allowed the operators to either use single or dual antiplatelet at their discretion, but again showed higher MACE and similar bleeding events. So the use of routine anticoagulation to prevent this HALT was kind of fell off after these trials. Now, what about patients who have an indication for oral anticoagulation? Should we add antiplatelet therapy in the early period? So this was the cohort B of the popular TAVI trial. So this was another 300 patients, not a large group of patients, but randomized them, allowed open either DOAC or warfarin on the trial compared to the addition of clopidogrel for 3 months. And in this trial, what we see is that both MACE and bleeding was increased with the addition of clopidogrel. So no benefit to adding clopidogrel in patients with an indication for oral anticoagulation. Then what about warfarin versus the novel oral anticoagulants? So do we need to use warfarin or can we use the NOACs instead? We have 2 trials looking at this. We have the Atlantis trial and the Envisage TAVI trial. Both showed similar results of warfarin to apixaban, both in terms of MACE and bleeding events. So either option is reasonable. And of course, as most of our patients, if you don't have to take warfarin, most don't want to. So NOACs was a safe option to warfarin, and there's no obvious superiority to using warfarin in these patients. So it's going to be hard to comment about master DAP, but I'll use it in this setting after Professor Kim's great lecture and great trial looking at this specifically. But looking at these patients with this, we extrapolate this into the oral antiplatelet arm in terms of patients with the PCI and how can we use it, and showed that the usage of the shorter duration of DAP therapy had similar MACE but lower bleeding risk. And again, similar in the patients with anticoagulation, the triple therapy, longer triple therapy showed higher bleeding risk and less MACE. So we can kind of extrapolate that into the TAVR database. So how do we manage these patients with no indication for oral anticoagulation? It's become relatively simple. If they're on single antiplatelet before TAVI, we load them before. We do that. We put them on the heparin during the case. If they have no stents, we do single antiplatelet and continue that indefinitely. There is no data showing aspirin versus PY12 inhibitor, so we don't know which is better in these patients. I think we can extrapolate coronary literature that potentially clopidogrel is safer, but I think most of us actually still do aspirin. That's what I do in my practice. And I think then for the PCI, you're going to use the evidence. Maybe we should be looking at like Professor Kim's trial and maybe do 3 months rather than 1 month, but short duration as possible because these do tend to be higher bleeding risk patients as PCI as you would. And most of these PCI in this setting is almost all elective and stable angina patients. And those who have an indication for oral anticoagulation, it's the same concept. You just continue the oral anticoagulation monotherapy, and then dual therapy can be reserved to those that have PCI, and then the length, depending on the duration, can be 1 to 6 months, depending on what your practice and the complexity of the PCI. Now, what we did see on the Galileo and the Atlantis trial, so yes, the overall favored not to use oral anticoagulation, but there is a real issue with HALT and leaflet thrombosis and reduced leaflet motion in these patients with TAVR. And so this needs to be addressed and kind of dealt with. And about a third of patients who were on the antiplatelet line Galileo and about 15% in the Atlantis trial had HALT. So we do see this early, and there is some evidence to suggest that HALT may be associated with earlier valve failure, structural valve deterioration. So these trials obviously were all short-term. So in the long term, this may be an issue. So we do need to monitor these patients. And across the trials, we do see that favors NOAC. So is there a patient population that would benefit? We don't have that data from these trials. But what we do know is that we need to keep a close eye on these patients. So when you have either, the easy one is when you have a symptomatic patient who develops obvious symptomatic leaflet thrombosis, and you work it up, you're going to put them on anticoagulation, and those patients actually probably need to be admitted and placed on IV heparin. But even the asymptomatic patients that we screen in the clinic at 3 months, and you get an elevated gradient, you want to put them on oral anticoagulation for the HALT at that point. Now, what do we do afterwards? I think that's still an area of limited data. When it resolves the HALT, what do you do afterwards? Do you continue them on oral anticoagulation or do you take them off? There's no real good data on the concept. In general, in most people's practice, and I would say in my practice, is if the patients are not at particularly increased bleeding risk, I keep them on NOAC indefinitely. If they fail the therapy or they do not respond adequately to their initial NOAC, then I would do warfarin with a higher target INR. Now we talk about TEER, kind of an undefined frontier. So in terms of what is the practice, so the first trials, the Everest 2, they did that for 30 days, then aspirin for 6 months, and actually stopped antiplatelets or didn't demand continuation. And if they were on oral anticoagulation, no antiplatelets. COAPT, if they were not on oral anticoagulation, left it up to the operators, aspirin plus minus clopidogrel for 6 months, up to the discretion of the operator. MITRA-FR actually recommended in their trial DAP for 3 months, then aspirin alone if no oral anticoagulation. And if there was oral anticoagulation, the addition of aspirin for 3 months. Again, these are all specified, no specific data for this. I saw this interesting German series of a few thousand patients showing what is the practice, and it's all over the map. So 22% of patients in this series had single antiplatelets, 12% of the patients had dual antiplatelet therapy, 21% had anticoagulation plus single antiplatelet, 19% just anticoagulation, 3% oral anticoagulation plus DAP, so triple therapy, and 21% had nothing. So it's kind of all over the map and depending on the center practices. I think the observational data does show some hints that there are higher rates of death and thromboembolism with no therapy versus single. And so leaving them on nothing is probably not a wise idea. If patients have an indication for oral anticoagulation, there are some evidence suggesting that there are higher rates of mortality with the addition of single antiplatelet therapy. So this is a US-based recommendation. So looking at antithrombotic options after TEER, and we can see that the current US recommendations are 1 to 6 months of DAPT, and then continuation of aspirin after that. If we look at the European recommendation, this is not a guideline recommendation, but this is one of the groups published in the ESC. And their current recommendation is actually single antiplatelet therapy long-term if there's no pre-existing indication for oral anticoagulation, and if there's an indication for oral anticoagulation alone. So my takeaway is I think in general in practice, if there's a need for oral anticoagulation, there's really no need for antiplatelets in the TEER subset. Single antiplatelet therapy is probably a reasonable choice for patients without an indication for oral anticoagulation, and especially if the patients that increase bleeding risk. DAPT is also a reasonable option for 1 to 3 months if there's no increased bleeding risk. So in terms of what I do, and I don't know if this is the right practice, but in our center we use DAPT for 1 month, then single antiplatelet therapy. But if a patient is at a particularly increased bleeding risk, we will keep them just on single antiplatelet therapy. Thank you very much.